Hello and greetings to all. Welcome to Physio TV Classroom. I, Dr. Tushar Sathe, Assistant Professor in Sancheti College of Physiotherapy, welcomes you all for Physio TV Classroom. Today we are going to see range of motion evaluation for lower extremity. In our lower extremity, we have hip joint, knee joint and ankle joint and other foot joints. So today we are going to see hip range of motions, in which we are going to see hip flexion, extension, abduction, adduction, medial and lateral rotations. As we know, hip is a ball and socket type of joint, so we have all these motions at the hip. So to evaluate the range of motion at the hip, we are going to see how we can evaluate the hip range of motion with using the goniometer over here. So to use a goniometer, ideally we should know what goniometer is. Okay, so firstly, goniometer is a device which can measure angle between the joints. Okay, so for that we need to measure the angle in between the joints. So we have a proximal arm, a distal arm and a goniometer. So I'll demonstrate on a goniometer. Okay, so this is a goniometer, in which here we have a stabilizing arm, that is proximal arm, a movable arm, that is distal arm, and the goniometer. And this point, that is the center of the goniometer, which we call it as fulcrum, which coincides with the axis of your joint, so that we get to know the correct range of motions at every joint. Okay, so now to evaluate the lower extremity goniometers, or to evaluate the lower extremity range of motions, okay, as it is a bigger joint and ball and socket type of joint, we need to have some bony landmarks. Okay, now we are going to see what are the bony landmarks over here, how we are going to position the patient, how the therapist position should be, and how we can check the range of motion for hip flexion, extension, abduction, adduction, as well as internal and external rotations. As we have seen the introduction of goniometer, now we are going to see how we can measure the hip range of motion. So for that, what we need to do is we need to take a subject in supine position. Can you lie into supine position? Here we ask the subject to lie in comfortable supine positions. Okay, now your hip range of motions are altered if your pelvic movements or pelvis is not in neutral. So for that, firstly you need to check for pelvis rotations. Okay, to confirm your pelvis is in neutral position, what we can do is, what you have to do, you have to palpate the ASIS, that is your anterior superior iliac spine, and PSIS, that is posterior superior iliac spines. If your both the thumbs are in normal or in equal level, that time we can call it as it's in neutral position. Alright, so how we can palpate the ASIS? That what you have to do is you have to keep your palm on the anterior aspect of your hip. So here you can feel a bony prominence, that we call it as ASIS. Now to perform hip flexion, so your hip flexion is movement of your leg towards your body side. Alright, it's happen in at your frontal axis and sagittal plane. So when you try to do hip range of motions, it happens at frontal axis and sagittal plane. So for that, to check range of motion, first thing you need to check is you have to do the passive range of motion first. First we'll do with knee straight, that is knee extended and knee flexed. Okay, so firstly what you can do, you can place your hand, therapist is in walk stance position, and then gradually you can lift the leg and you can feel the end of the motion, that is end fill. Here it is firm, and when you do with knee flexed, here you can see again we are getting a firm end fill at the end of hip flexion. So here we can get two end fills, that is firm and soft end fill. If your structures are stretched at the end of the range of motion, posterior structures, then you will get a firm end fill. But if your anterior structures are approximating on each other and you get a soft end fill, that time you will call it as soft end fill. Now, once you have come to know how much range is possible with the passive range of motion, now we will evaluate with the use of goniometer. Firstly, mark the anatomical landmark over here. What we can do is we can ask the patient to keep hand on over the chest. Then from the palm we have to keep it on the lateral aspect of the hip and ask the subject to move his leg. Now over here a bony prominence will move under your palm. Here you can palpate that it's a greater trochanter. So your greater trochanter lies at the axis of your joint range of motion. So here you can mark over the pen that this is a greater trochanter. Now here this bony landmark will coincide with the axis of your goniometer, that is your fulcrum. Now here we have marked, so this way you can keep the goniometer over here. Then after this, your stabilizing arm, it will be parallel to the lateral aspect of your trunk, and your movable arm will be parallel to the lateral aspect of thigh and pointed towards the lateral epicondyle of the femur. So this is how you can position the goniometer to check the hip flexion range of motion. Now as we have positioned the range of goniometer, then we can ask the patient to flex the hip with knee flexion. Can you do the hip flexion with knee flexion? Yes. And go down. Alright, now we have seen this motion as active range of motion, as patient or the subject has performed this range of motion actively. Now what we can do is we can stabilize this, and passively we can check this, how much range of motion can be possible. Alright, now here when we do hip flexion actively and passively, here we get slightly 10 to 15 degrees of difference, because passive range of motion goes more than the active range of motion, and the normal range of motion for hip flexion, it is 120 degrees to 140 degrees. Now we are going to see how we can perform or how we can check the extension range of motion, that is your hip extension. Again we have similar anatomical landmarks, but the patient's position will be in prone position. Can you go into prone position? Yes. Now for hip extension range of motion, the patient's position will be in prone lying position. Then you have to again see for posteriorly PSIS, that is posterior superior iliac spine, it should be in normal levels. Alright, once that is done, what you have to do, then you can stabilize the pelvis over here. Then similar landmarks, again what we can do is on the lateral aspect of the hip, we can check the greater trochanter as we can palpate over here, and in similar fashion we can keep the goniometer. That fulcrum will be at the axis of the joint and movable arm will be at the lateral aspect of the thigh pointing towards the lateral epicondyle, and stabilizing arm will be at the lateral aspect of the trunk. Okay, now here we can ask the subject to perform a hip extension with knee extended. Can you do hip extension with knee extended? Yes. Relax. Now over here we can see this was active range of motion which is performed. Now with stabilizing at the thigh we can perform passive range of motion and relax. So again here you can get 10 degrees of difference in active and passive range of motion, and the extension range of motion normally is present as 30 degrees to 35 degrees in normal individuals. So if it is less or more in any subjects, then again try to evaluate one more time and try to minimize the errors. Even if it is there, the range of motion is less, or if it is more, then we should need to check for any pathology at the hip joint. Okay, that's how we can do the hip flexion and extension. We have seen hip flexion extension range of motion. Now we are going to see how we can measure hip abduction and adduction range of motions. So for that, again we will need to be in supine position. Now here your hip abduction range, abduction is your leg going away from your midline, that we call it as abduction, and your leg going towards your midline, that we call it as adduction. So for abduction adduction to happen, the axis is parallel to the sagittal axis and the movement happens in your frontal plane. Okay, now to perform this abduction adduction, the bony landmarks for this is, first is ASIS. The ASIS will be the fulcrum for abduction adduction. So to palpate ASIS, again you have to keep the hand on the pelvis, and the anterior aspect you will feel a bony prominence, that we call it as anterior superior iliac spine. So before we go ahead, we need to see first that the patient or the subject is in the comfortable supine position. Then your hip should not be in flexion or in extension. The again it should not be in abduction or adduction, and in neutral position, nor in external or internal rotation. Okay, so this is the ideal position to check the hip range of motion. Now we are going to check hip range of motion for right side for this subject. Here, as we have done passively, again we will do a passive range of motion in a walk stance position. So here we get a firm end feel over here at the end of passive range of motion. So your fulcrum will be at the ASIS, and stationary arm will be parallel to the imaginary line from one ASIS to another ASIS, that is now from right ASIS to left ASIS. So this way you will keep the goniometer over here. Now for your movable arm, it will be parallel to the anterior aspect of the thigh and pointing towards the patella. So this is the ideal position we can keep for hip abduction and adduction. Now we'll ask the subject to move his leg outside of the plinth. Okay, can you move your leg outside of the plinth? Okay, relax. Now over here, our initial starting position will be from 90 degrees and the end position was for around 120 degrees. So here we have got 30 degrees of hip abduction, and ideally the normal range what we get is 40 to 50 degrees of hip abduction. Now what we can do is, as it was active range of motion, we can do a passive range of motion and check for the hip abduction range, and over here we can get additional 5 to 10 degrees of increased range of motion, as this range of motion was passively done. So that's how you can check for the hip abduction range of motion. Now we are going to see how we can check the hip adduction range of motion. So for that, the position of the subject again will be in same position, but the contralateral side leg will be slightly abducted, so that we'll have room for adduction range of motion, and that's how you can check for adduction range of motion. Firstly, what we have to do is, therapist is in walk stance position, and passively we have to check how much adduction it can go. Once we have estimated that passively this much adduction can go, and the end feel, again we get a firm end feel over here. So the placement again for the hip adduction range of motion is, ASIS is the fulcrum, the proximal arm will be parallel to the opposite ASIS, the line which is made from right side ASIS to the left side, that is imaginary line, and the movable arm, it will be at anterior aspect of the thigh pointing towards the patella. So here we can ask, firstly actively move the leg inside, that is towards the other leg. So you have to move the leg towards your other leg. Yes, very good. Again back to normal. Yes. Now we have seen actively how we can perform the hip adduction range of motion. Now for passively, again you have to grasp at the thigh and move inside. So here we get a additional range of motion. So the difference between two active and passive range of motion is slight, that is around 5 to 10 degrees, but ideally normal range of motion for adduction is 15 to 20 degrees. So now, as we have seen, hip flexion, extension, abduction, adduction, the remaining which we have left are with hip medial and lateral rotation. Okay. To see what is hip medial and lateral rotation, we'll first see it in supine position. We go into supine position. Okay. Now, so your foot going in is your medial rotation and out is your external or lateral rotation. But with knee extended, foot going in and out will be your internal and lateral rotation, that is medial and lateral rotation. Now to confirm how it's internal or external, what we can do is, we can keep the palm on the lateral aspect of the hip where we can feel the greater trochanter. So when we try to move the leg internally, the greater trochanter moves anteriorly, and when we try to move it laterally, the greater trochanter moves posteriorly. So that's how we can confirm it's an internal and external rotation. Now it changes with knee flexion. So we'll ask the subject to be in sitting position. Come into sitting position. So again here, if we see, if your foot is going in then ideally it should be a internal rotation as we have seen in knee extended. But when we flex the knee, again what we can do is you have to keep the hand on the lateral aspect of the femur and then move the leg. So when your foot is going in, the greater trochanter is moving out, so this is your external rotation. And when your foot is going out and hip greater trochanter is moving in, that time we call it as internal rotation. Again, this confusion might happen in prone position, so again we will try to show in prone position. We go in prone position. So for again prone position, flex the knee, keep it on lateral aspect. So when the leg is going out, the greater trochanter is going anteriorly, that is your medial rotation, and when it is going out, that is your lateral, that is external rotation. Now to check range of motion of medial and lateral rotation, so first thing is the patient's position. So we'll ask the patient to be in seated position. So the ideal position is sitting position with knee out of the bed, hanging down, not stabilized by the ground or any stool. Patient is in straight erect posture. So here the bony landmark is the base of the patella, that is anterior aspect of the patella. Here is the fulcrum of checking the medial and lateral rotation of the hip. So for here again the fulcrum will be at the anterior aspect of the patella and the stabilizing arm will be parallel to the anterior aspect of the tibia and it will be perpendicular to the ground, and the movable arm again will be parallel to the anterior aspect of the tibia. So now when I am doing this range of motion, so from 0 we are taking an internal range of motion. We can do it as passively and ask them to do it actively. You have to take your leg out. Yes, relax. Alright, this is for internal rotation, and similarly we can do it for external rotation, that is taking the leg in. Alright, again do it actively. Yes, relax. So for internal and external rotation, the internal external rotation normally is 30 to 45 degrees for internal rotation and 40 to 50 degrees for external rotation. So your external rotation range of motion is more than the internal rotation. Okay, and in both the range of motions, when you do passively, you can get a firm end feel at the end of the motion. Okay, now when you are documenting this range of motion, ideally the format should be the name of the subject, age, gender, the time, and on the which date it has been checked, and by whom the therapist initial, with which type of goniometer, it's a full circle or half circle goniometer, then on which side, as we have checked all the ranges on the right side of the patient, that again we have to mention for the right hip range of motion, again mention for which range of motion, that is flexion, extension, abduction, adduction, or medial and lateral rotations, and it can be documented as active and passive range of motions, and hence this is how you can check the hip goniometry range of motion. Thank you so much. Thank you so much for joining this session. I want to thank Dr. Parag Sancheti sir, our chairperson, and Mrs. Manisha Sanghvi ma'am, our executive director, for giving this opportunity. and our beloved principal Dr. Apurva Shimpi sir for giving constant support for doing this. Also our technical team for giving this for recording this session, and the viewers for joining this session. Hope to see you in next session. Thank you.